Good evening. Thanks for the opportunity to speak this evening with y'all. So my name's Paurush Babbar. I'm one of the urologists here in town at the urology group. Um, so what I want to talk about today is life after prostate cancer. So I think the y'all's group, I'm sure, has talked in depth about prostate cancer, the ins and outs of treatment, and what we do for patients on that journey. But I think a part of this whole journey that when we look back at patients who have dealt with prostate cancer 5, 10 years ago, what is something that we as a medical field lacked was potentially guiding patients through their life after the treatment for prostate cancer. And I think that side effects, let's say, that patients may see, what are some things that we can help patients on this journey to expect, and what are things that we can do to mitigate some of those side effects. I did my medical school training and my undergrad at Wake Forest University in North Carolina, and then I was fortunate enough to go to the Cleveland Clinic, which I think is one of the most the preeminent institutions for urologic care in the U.S. And then I was able to stay on for a fellowship after my 6 years of training in male genital urinary reconstruction and prosthetic surgery and men's health, and so. This is kind of my passion, which is helping patients navigate their prostate cancer journey, and then helping with some of these things that you can see here that some patients with or without prostate cancer can deal with, namely incontinence, erectile dysfunction, penile curvature, testosterone issues, testicular pain, things of that nature. So your cancer doctor gave you years to your life, and our job as a men's health specialist is to give life to whatever remaining years there are. So I think managing sexual health is absolutely critical, because I think that one's perception of self is very intermittently intertwined with one's sexual health, how continent we are, how we feel in the bedroom, our sex drive, all these things, things that are hard to quantify, but once you lose them, for instance, we don't think about how important continence is, but patients, the 7 to 10% of patients who, after prostatectomy, may have leakage, they are the ones who can really tell you that once you start living life in diapers, how debilitating that can be and how that can affect one's self-confidence and self-worth. And so, I think as a field, we need to do a better job in kind of spreading the word about this and just helping patients navigate this journey. So, one of the things we want to talk about is erectile dysfunction. I think whatever treatment for prostate cancer that may be given, prostatectomy, radiation, uh, ADT, androgen deprivation therapy, I think some degree of erectile function dysfunction can be seen. Also, because prostate cancer, for better or for worse, is a disease of older men. You don't see this in 20-year-old guys, right? So, and I think as we get older, erectile function does start to dissipate with age, and we know that 50% of men over the age of 50, who are just all patients, will have ED. And so once you add on a prostate cancer diagnosis with the subsequent therapy, I think erectile dysfunction is quite common. And so we know that sexual dysfunction, I mean, the percentages are so widely varying, because I think that it's just hard to fully intertwine. Is it from the treatment, or is it just part of aging, or is it diabetes, or is it trauma? What is it? But I think that I quote patients, 45 to 55% of men after any prostate cancer treatment will have severe erectile dysfunction. And once you start adding on, patients who have prostatectomy, who may have biochemical recurrence, they get radiation and they get, androgen deprivation therapy, I mean, the rates go much higher. So it's quite prevalent. Like I said, more than 50% of men over the age of 50 will have it. 20% of American men over the age of 20 will experience ED in their lifetime. In a young guy, it's a totally different ballgame. It's generally psychogenic. It's some kind of stress or situational anxiety. But, as we get older, there's more organic causes of ED. And we think at least 30 million American men are affected by erectile dysfunction. So we think that ED common causes could be medications. Things I think about, ADT is one that this group would be aware of. Then antidepressants, some blood pressure medications can do it. Pelvic surgery, prostatectomy being kind of the most common one, but even colorectal cancers, rectal cancers that get operated on, I see those having issues with that. Testosterone absolutely implicated. Now this is bit nuanced here in a prostate cancer survivor, how we manage that, and certainly we can delve into that. But certainly just low testosterone in of itself can more so affect sex drive and libido, but can also affect erections. Radiation therapy of any sort, definitely prostate, colorectal, once again, bowel cancers can also do it. Depression, anxiety. I mean, I don't think we can understate how important that is. Just because if you're not in the mood, if you're not feeling, if you're going through a tough time, it's kind of hard to have sex. I think you have to be mentally kind of in a good spot a lot of times to be able to enjoy that. And then obviously treatments for prostate cancer. So and then the last part, I think I tell patients anything that helps your heart, anything that your cardiologist has ever told you helps, I think helps your penis. We know that the penile blood vessels are half the size of our coronary blood vessels. So, things that build up plaque in a coronary vessel and cause a heart attack, that same pathophysiology, the penis is not spared from that. So, meaning if you eat super unhealthy and you start, building up plaque deposits in the penis, it stands to believe that is going to cause some degree of decreased blood flow to the penis, which it only takes a 10 to 15% decrease in blood flow velocities to see a decrease in ability to penetrate during intercourse. So ED after prostate cancer treatment. So I think the key part of this slide is that the nerves that are important in the erection pathway run on the the sides of the prostate. And so this slide shows that when you do a prostatectomy and remove it, that if your surgeon is able to, with oncological things in mind, do a nerve sparing prostatectomy, they will try to spread that apart, but it's still maybe difficult to fully gauge how that heals. And then radiation, I mean, yes, the prostate's left in situ and you radiate that area, but there can be some scatter to the nerves. And so that absolutely can do it. And then, with androgen deprivation, it's kind of a different pathway. I think it's more related to the testosterone being cut off a lot of times, and then your sex drive is not as good. But I think when a patient gets ADT, he may have had some, radiation or prostatectomy with it that also contributes. So the way I think about ED treatments, I think of the 5 Ps, the pills, which is everyone's heard Viagra, Cialis, certain supplements, which I think that there's certain studies on that, and things that come to mind: L-arginine, ashwagandha root, things of that nature. Pulses. So this is low intensity shockwave therapy, which I think is something that's all over the radio waves, commercials, things of that nature. I think there's been a couple of studies in prostate cancer survivors which shows that it's not the best treatment option, because I think the impairment in the nerves a lot of times means that in shockwave is not as good as in a patient who has not had prostatectomy. Pokes, which is intracavernosal injections, or urethral gels less commonly. Then pumps, or which is vacuum erection device. Restorex, which is more of a treatment, I think, for Peyronie's, which is penile curvature, but we do know that in pre-prostatectomy prehab, so one thing patients will notice after prostatectomy is they may have lost some length and girth, and so doing Restorex pre and certainly post-operatively can help mitigate some of that, and then procedures with a penile implant, which we'll delve into. So in regard to oral medications, I'm going to kind of breeze through this a little bit, because I think we a lot of us would know what these are. So Viagra, Cialis came about in the late 90s. And essentially what these medications do is they increase blood flow to the penis. They obviously require some form of sexual stimulation. So meaning you're not going to be walking around with an erection willy-nilly. It's an effective in the majority of patients, but that's upfront, right? When they first started. And then over time, as the ED progresses, you may need a higher dose. And then patients who have had prostate surgery, diabetics especially, they may not be as effective. So Viagra, you take 30 to 60 minutes before on an empty stomach. Cialis, more so, is kind of the weekend pill. You take it sometimes daily dosing, sometimes a couple hours before, and usually work pretty well in most patients. Side effects: headaches, facial flushing, nasal congestion. So it essentially increases blood flow to your head, and that is what causes those side effects. This is just, we have an in-house pharmacy at the urology group, and we dispense it. That's what that's saying. So the vacuum erection device. So this is a hollow plastic tube that is put over the penis, and a lot of times you use it in conjunction with a constriction band at the base of the penis. So this is effective in a lot of patients, but still the vast majority move on, because it's not very conducive to a spontaneous experience. There's discomfort for some patients with the constriction band. Sometimes the rigidity isn't good enough. Like, it looks good in the vacuum erection device. Once you pull it off, there's some degree of leak of the blood, let's say, and then they can't perform. So now One area though where I think a vacuum erection device is a very good idea is in prostate cancer patients, especially ones who are going to be undergoing prostatectomy. So at the urology group, we have a pre-prostatectomy prehab program that we've started. And so what we do is once one of our oncologists, you guys may have Dr. Delworth, Dr. Wirtz, all these guys, they order a prostatectomy. We automatically reflex an order that the patient is offered an appointment with myself, my men's health team to meet pre-operatively to surgery. And we kind of go through a lot what we're talking tonight. And the one thing I talk to patients about is starting a vacuum erection device preoperatively. Why I like preoperative is that at that point they're not having any pain, right? Like they may after prostatectomy. And so twice a day for 15, 20 minutes, if they can, you put that vacuum on and get some blood flow to the penis. And then, especially once the catheter comes out after prostatectomy, we have them really try to do that again. Now it'll hurt a little more, obviously, because they just had surgery, and so but the more they're facile with it, the better. And we know that patients who use a vacuum erection device at these times will have faster recovery of erections, better recovery erections, and also less loss of length and girth that can be reported. And I do think there is some inevitable loss of length and girth with prostatectomy. Oncologists may not fully agree with me, but I think once you pull the prostate out and you have to sew your bladder to your urethra, just that day itself, it's going to pull back to some degree, and so everyone's prostate is a different size, right? So everyone knows that going in because you've probably had a prostate MRI or an ultrasound of the prostate, but I think that is not uncommon and it's not untrue what patients tell us. And so I think that doing this helps. And then the other thing we do in this regard is from a couple slides ago is I like to start patients on a low dose daily Cialis, because I want to increase blood flow to the penis on a minute by minute basis. And there's actually good studies that show that starting that prior to surgery helps with, once again, better recovery of erections, faster recovery of erections. And patients continue this throughout, right? Like I tell guys, think of this as you're going to take this going forward. So those two things seem to help. And then the really motivated patients that I didn't add it to these slides, but the Restorex device, which is more very much indicated for Peyronie's disease, which is a penile curvature and it curves in the opposite direction, but you can also use a Restorex to kind of extend the penis forward. And there's the studies out of the Mayo Clinic show that there's about a 1.4 centimeter decrease loss of length in prostatectomy patients who use the Restorex. So, but it can be a little more painful, a little more challenging to kind of apply. Insurance doesn't cover it that I know of. It's about $500. So there's some cost to it, but in motivated patients, we certainly recommend that also. Next treatment option for erectile dysfunction is intracavernosal injection therapy. So instead of a pill like Viagra Cialis that goes throughout the body, you're injecting directly into the penis. It's self-injected. Erection typically 5 to 10 minutes after. Most of these need to be either refrigerator or frozen. Limited shelf life. Like if you leave this medicine out on the counter after you use it, it will denature a lot of times and it will not work as well. You have to special sterile compounding pharmacies have it. So it actually works pretty well. I think when I tell patients injections work well, it's that the side effects are kind of where most people will say, okay, I'm done. I don't want to do this. One is obviously putting a needle in your penis every time you have sex gets old pretty quickly for a lot of patients. Bruising, pain, swelling, development of scar tissue can certainly happen in certain patients who have that preponderance for that Peyronie's or penile curvature. And then there is rate of priapism, which is the prolonged erection, which you may have heard about, which is where you have to then either you have to go to an ER and get the antidote put in to bring that down. So now injection therapy, I think, is a good option once again in prostatectomy patients who let's say are 6 months out, they're motivated to be sexually active, and the pills and the vacuum just aren't enough for penetration. I sometimes think this is a nice boost to kind of help regain some function. Now, whether if they are able to recover and get off the injections, I've seen that, and that's good. But sometimes patients, if they're in, they like using it, they can continue. But I do find that I like it in that patient population more than diabetic. Like if a patient's a diabetic, I mean, we can talk about like they're good with needles, but it's like, what's the long-term goal? Like, unless they want to continue injections for 10 years, which most patients don't, I think in a prostatectomy patient, that first year or two, like using the injections can sometimes maybe kickstart or trigger their erections back. But if it doesn't, then we look at the next option, which I'll talk to you about, which is the penile implant. So Shockwave, I'm going to go into this kind of briefly here because I just don't think this is like the right population that we recommend this on. So Shockwave, I mean, it's all over the airwaves, so to speak, just because I think that it can be administered, by really anyone. That's the thing you have to be careful of. So there's two types of shockwave: radial shockwave and focal shockwave. So focal shockwave, you have to be a medical provider, like a board certified urologist to do. Radial shockwave is an FDA class 3 thing. I mean, anyone off the street, if you have enough money, you buy one of those and you can set up your own clinic. That's where, as you can follow my drift, things get a little iffy, and it kind of sometimes becomes a bit of an issue. So I personally, when I see if there's a prostate cancer patient, who've been through the therapy, there was 4 clinical trials on patients who've had prostatectomy, and 3 showed absolutely no benefit. 1 was a maybe. So I think, especially in this day and age where this is not covered by insurance, I just don't feel right, like, asking patients when we don't have good data that it would help. Now, like I tell guys, look, it's not going to hurt anything. That's the good news. All the trials show that there's no, penile pain or bleeding or anything like that. So, if there may be some placebo effect, and once in a while I have a prostate cancer patient who's adamant, look, I absolutely want to do this. I understand what your data says, and look, you can, it's a free country, but I think that in prostate cancer patients, it's not our best treatment. Penile implants, I think, is something that is interesting, and something everyone should know about. I think it's something that patients, when they first hear about it, they're scared of. But I think once we kind of delve into it, it's especially in prostate cancer patients, diabetics, patients who've had other, colorectal malignancies, something that you should know about, not be scared of. I think a penile implant, to me, is like a knee replacement of the penis, right? So if your knee wasn't working, your orthopedic surgeon, he or she would say, okay, here's some Tylenol and Motrin. Think of it like Viagra and Cialis. If that didn't work, they would say, here's a steroid shot in your knee. Think of that like an intracavernosal injection we just talked about. And if that's not working, or you're having side effects, the orthopedic surgeon says inevitably, okay, either get a knee replacement or live the rest of your life in a wheelchair. And I'm still waiting to meet a patient who says, give me the wheelchair. Now, penile implant surgeries take about half as long of time in the OR as a knee replacement, and they have about half the recovery and complications. So penile implants have been around since 1973, longer than Viagra, Cialis, injections, all these treatment options. Now, the technology's come a long way, a very long way. But the idea of putting cylinders in the erection chambers of the penis, which is called the corpora, has been around for over 50 years. So this, on this side, this shows a 3-piece inflatable penile prosthesis. There's a pump in the scrotum. There's 2 cylinders in the erection chambers of the penis and a reservoir deep in the abdomen. So when you want to have sex, you grab the pump, give it a couple squeezes. It goes from not hard to hard. Patients can have sex whenever they want, as long as they want. They do not have to worry about not being able to initiate the erection. They will not lose the erection. They can have sex 4 hours, 5 hours, whatever you need to do what you got to do. Over 95% patient and partner satisfaction. The most common thing in well-selected patients who we do this is they say, I wish I did this sooner. There's another type of penile implant with just 2 rods that can be put in the penis, no pump, no reservoir. That's kind of in more select cases, patients who have what's called a buried penis, where they can't see their penis. We need to push it out so they can have sex and they can hold it to pee. Patients who may not have good hand dexterity, MS, Alzheimer's, not Alzheimer's, sorry, MS, ALS, that's what I meant, things of that nature. And then even I sometimes think patients who have an artificial urinary sphincter, which we'll go into, I think sometimes they do well with a malleable too. So I think it's something that, it's not right for every patient, but I also think that we need to, especially in prostate cancer survivors, at least have a good conversation about this. And so the 2 main risks of the penile implant, one is the risk of device malfunction on the inflatable one, which is essentially fluid leak. If you think about like your car tire can pop a leak, this can leak. The risk of that is 6% at 7 years. So 94% are working 7 years out. Average lifespan of a Boston Scientific implant is 12 to 13 years. So at that point, if you need to replace it, it's like a 45-minute operation to even put one in or replace it, and you go home the same day. And then the other risk is infection. Infection rates 2 to 3%, just like any artificial knee, hip, heart valve, any implant in the body. That really relates to surgeon experience. Just like anything, the more you do, the faster you get at, the better you do it. So I do the most of this operation in Ohio, and so we do over 150 a year, and our infection rate is below 1% at this point, which is good. So this video is working. No, it's not. So when we'll have to figure that out. So the other thing I want to kind of talk about, things that I think these are of interest, I think, to prostate cancer patients. So specialized procedures that kind of go along in the ED treatment, that things that you may like just say, oh, this is life, but it doesn't have to be, right? So one thing is a crooked penis, right? So some patients after prostatectomy, just because they haven't had good erection, they've been trying to have sex with a floppy penis, they get like a crooked penis and a not rigid one. So when you put a penile implant in for per se, you can actually straighten the penis at that same time, and you're as good as new, so to speak. Another one that's kind of a newer technique, which I'm a big proponent of, is a midi Jupette sling. What this means is some patients after prostatectomy will notice that they leak urine when they climax, right? And so they're not leaking urine anymore on a day-to-day basis, but when they climax, when they're kind of having foreplay with their partner, they'll leak, and it's just a bit disconcerting. And so at the time you put a penile implant in, you can add this sling, and like this image shows, adds about 10 minutes to the procedure. And then on this image on the right shows that when the implant inflates, it compresses the urethra so they don't leak during intercourse. They don't make a mess with that, which is good. The partners love that. And then also you can leave the implant like half inflated on a day-to-day basis, and you can get some continence out of that. So that's something to think about. An suprapubic lipectomy, what this is, especially patients who've had androgen deprivation, they may no fault of their own, but their T level gets plummeted super low. They start putting on weight, and then a lot of it can kind of accumulate right above the penis. That's called the panniculus, or the escutcheon is the other medical name, suprapubic area. So we can remove that fat pad, and through that we can put a penile implant in one operation. And that, cosmetically looks good. It kind of helps with perception of self a little bit. So just other things to like that. Just doing a lot of this, we kind of figure out ways to just help patients in their individualized case. So another thing that I want to go into is incontinence after prostate cancer. So this is more prevalent in patients who had prostatectomy. Now, it can happen rarely in radiation patients who get a narrowing in the urethra and maybe have to be dilated or have their urethra scraped out, the prostate scraped out, but really more so seen in after prostatectomy. So 8 to 15% of patients after prostatectomy will have incontinence a year out. Now, I've seen varying kind of rates on this. I quote 7 to 10, up to 15. But it certainly is common. And so things that can be done. Okay, so the first three things on the left are just, to me, temporizing or band-aid solutions, right? So pads. That thing there is called a Cunningham clamp that essentially clamps across the penis. The thing on the middle is a condom catheter. So you put a catheter which has a condom and you leak into that. So these are options, especially, I mean, like in the first couple of weeks after prostatectomy, if anyone's had it, you'll know that you'll leak urine. It's just while you're strengthening your pelvic floor and getting used to not having your prostate, it's inevitable. But over time, the goal is that you're down to 0 to 1 small pad a day, maybe if you're doing some exercise. But if not, then these other options on the right come into it. So one is a male sling, and then the second is an artificial urinary sphincter. And so this is a QR code. There was a documentary series done on one of my patients, Roberto, just last year. He essentially had prostate cancer in 2017, had a rough course, was in the hospital, I think 9 days after his prostatectomy, and just kind of had a very rocky course, to say the least, and had biochemical recurrence, got radiation, and then kind of I met him in 2020 when I started at the urology group, and we talked about trying to get him dry. He was leaking 8 to 10 pads a day. We installed an artificial urinary sphincter. He got dry. Then after that, he was like, okay, look, I never thought I could have sex. I was leaking so much. So we put a penile implant in him, and then now he was able to have sex. And then, he was a couple years out from his prostate cancer, and we actually started him on testosterone. So now he, had some more sex drive. He was able to work out more. He had more desire, motivation, and he's lost a lot of weight, and he's working again. So, I mean, it's just like, it's what I love what I do. It's my passion. I'm happy to go to work every day just for cases and stories like this, and so I encourage you guys to check that out, because I can speak to you as the surgeon on these cases, but just hearing from someone who's kind of been through that journey is even more impactful, I find. So incontinence, we all know what is leak of urine. essentially the bladder will store urine. It comes out through the urethra. The sphincter muscle surrounds the urethra. So when the prostate is removed, a lot of times that sphincter muscle can be damaged or doesn't work as well as it used to, and that kind of contributes to the leakage. And the type of incontinence generally seen after prostatectomy is something called stress incontinence, essentially meaning when you cough or sneeze, or bear down your abdomen, you leak. These discuss more the prostate cancer specific stuff. And the other thing that radiation can also cause a form of incontinence called urgent incontinence. That's the other form of incontinence, just where if you got to go to the bathroom, you got to go now, and if you don't make it, you'll leak. So that's urgency incontinence. And that really relates to a lot of times from the radiation, there can be scatter bladder, and that makes it less spasms, and you can leak. So up to 50% of men will report leakage immediately following surgery for prostate cancer. And so that's why when we meet patients in their meetings, we have, I think, if it was Dylan Hagel talk, I guess we didn't talk about it, so let me talk about it. So Kegel's exercises are pelvic floor strengthening exercises that we recommend patients start prior to prostate cancer surgery. Essentially, the way I think of a Kegel exercise is if you are peeing, if you try to cut your stream off halfway, that muscle internally that you have to kind of contract to do that, that's a Kegel. So then I tell patients, okay, now that you've kind of understood what it is, I want you to keep flicking that muscle over and over again. Do it at least 1,000 times a day before surgery, and sometimes hold it and let go, hold it, let go. Now, we also do offer pelvic floor physical therapy appointments if patients want, before surgery and certainly after the procedure if they're still kind of struggling with incontinence after. And then in patients who, let's say, at least maybe 6 if they're leaking a lot, or 12 months out if they're leaking a little less, they're persistent leakage where they're going through pads, then we talk about surgical solutions. And the reason is that medicines are not going to help stress incontinence. Stress incontinence is a total anatomic problem because your sphincter muscle is not opening, like it's not closing as it should. So giving medicines just, I think, puts a band. It doesn't do anything, actually. Forget a band. It literally doesn't do anything. So you have to, unfortunately, do a surgery. But I think I tell these surgeries take 30 to 45 minutes. You're home the same day, and it can really help. So the first thing is a male sling, Advanced XP sling. So essentially, this is like a hammock that tensions up on the urethra and supports it. It's done through a small incision underneath the scrotum. Over 90% of patients said they'll do it again. But I think the key on this is it has to be a well-selected patient. It has to be someone with mild to moderate incontinence and not radiated, in my opinion. And so I think those patients do the best with the sling. And then the other procedure is called an artificial urinary sphincter, an AUS. And so this essentially is a cuff that sits around the urethra and it's closed at baseline. And when patients need to pee, they'll press that control pump that's there, and that opens for about 45 to 60 seconds, and then on its own it closes back down. So anyone who's leaking more than 3-4 pads a day, who is radiated, I think they do better with artificial urinary sphincters. And once again, this is a 30-minute procedure. We did one this morning, took 30 minutes, and patients home. So I think it's pretty benign. I mean, hopefully you don't need to do it. Like I said, 7 to 10% of men after prostatectomy may need a procedure to regain continence. So it is possible. So the reason, I love to go into this before surgery with patients is that, we hope they need none of this, right? That would be obviously the goal. And I think as the robotic surgery has kind of been more prevalent, like for instance, we see less AUSs put in than when open prostatectomy was a thing many years ago. But God forbid something, it doesn't come back. The erections aren't there. I don't want people to suffer in silence. I think that's where we drop the ball as a field. I think, and so I, once in a while, every couple of weeks, I'll meet a guy who, I just met a patient recently who had his open prostatectomy in 1996. He was in his 80s. He's been leaking since then. He's been wearing pads. I mean, it's sad. It's just like, there's no need for that, So we've installed a sphincter, and he's dry now after all these years. And so I tell guys, like, we can address it. Like if you have, if you're a couple years out from surgery, you don't have not had sex with your wife and you want to, let's do it, let's make it happen. So I think it's just, you just have to tell it to us, and we can help. Um, so the key is don't give up. If one treatment doesn't work, we'll find another one that does. If you've had a bad experience with one physician, meet someone else. If you meet me and you didn't like what I had to say, get a second opinion. I find nothing wrong in that. But in the end, I think all doctors, we went to medical school to help patients. We want patients to live a long, fulfilling life, and anything we can do in our expertise to help, I think, is what we want to do. So yep, that's me. If I can be of assistance to anyone, I see patients in Eastgate, Norwood. Actually, now I even go to the West Side, and I go to Blue Ash just to kind of do men's health and do what I'm passionate about. So um, let me pull this back up. If there's any questions, I would love to answer those.